I would like to use this hour that we'll be staying all together, discussing in a very informal manner on how we can do ESD, how we can train for doing ESD, what are the technical aspects that we should know before starting, and hopefully this will be informal and very interactive breakfast meeting, and I suggest everybody to put the hands up and to start with question. But just the first question to me is for both of you. Which year you started doing ESD, your first ESD?
Which year? 1997.
It was colonic?
I started both the colonic and gastric at the same time. And first case I did was the rectal lesion.
Okay. What about you?
So for me, 2000.
So your first ESD was in 2000?
Yes.
It was esophageal one?
Yes. Yeah, I don't remember well. I don't remember well, but the esophagus or stomach.
Can you roughly say how many ESD cases have you done in your career until now?
1,000, more than 1,000. More than 1,000.
You?
I don't count, but probably more.
Oh, you don't count. That's good. That's good.
Maybe I'm doing.
So can we say
Japan,
that in your practice
Yes.
you do mostly ESD for colorectal lesions or not?
No, about same number or a little bit more in the gastric lesions.
A little bit more.
Yes.
What about you? More esophageal, more gastric?
Mainly esophageal and gastric.
Mainly esophageal and gastric. So we know that everybody loves to use their own knife, okay? And we have a wide range of knives available into the market now. And you created the TT knife. You are the inventor of the flash knife. So
No, actually not. I invented safe knife, but
safe knife?
Yes, flash knife was invented by Dr. Toyonaga.
Okay. So which kind of knife you use?
I use flash knife and safe knife.
So regardless of the location. So
right. Depends on the location and approaching angle, and I select a flash knife and the length of knife and the for the lesions which I approach vertically, then I like using safe knife.
So what about you?
So I myself originally use a TT knife for any kind of ESD, but after that I switch my devices to dual knife or a flash knife.
Flash knife.
Yes, so I myself now do not use a TT knife for ESD. So
Okay.
TT knife is only for
Poem.
poem. Yeah.
So this is a big change because I saw you doing many ESD cases in the past with TT knife.
Yeah.
What was the reason for changing the knife? Can you explain us?
So very beginning of the procedure. So basic concept is TT knife. Basic concept is hook the tissue and then cut. But so we are familiar with the technique, and then so TT knife is too large to cut the tissue. So we can do a more precise dissection. I myself, yes,
Okay.
so because of the running curve. Then I switch the device to dual knife or flash knife. And then TT knife, but the TT knife is a very nice device for good matching to our palm procedure.
Okay. So question for both of you. When you schedule a patient for doing ESD, is the patient admitted as inpatients, so is in the hospital, or is as outpatients?
In my hospital, we schedule as an inpatient.
Inpatient. So he's admitted the day before?
Yes, right.
You too?
Yeah, so we also are inpatient, but the same day. Admission the same day.
Same day.
And then stay some days
Okay.
hospital. Yeah.
So which kind of preparation for the patients? I mean, anesthesiology consultation or blood test or...
Yeah, for patients with comorbid conditions, then such as heart disease or lung disease, then anesthesiologist consultation we make. But for just a healthy patients, we don't consult the anesthesiologist. And
Any blood test?
yeah, blood tests, the regular blood tests, including the CBC and the chemistry and blood sugar. So just a fundamental.
So yeah, generally same to Dr. Yamamoto, and so something additional. Important thing is the patient take anticoagulant or not.
Yeah.
So if
Right.
the patient take anticoagulant, so at the time, so we consult the cardiologist.
Cardiologist?
Yes, and then get a recommendation from them. So we can stop it right now, or we should do some heparinization or not. So like that.
So there has been a paper in endoscopy, I remember it was beginning of this year, showing from Korea that if you do ESD under aspirin, you have twice the risk of getting post-procedural bleeding. Okay. So your suggestion, if a patient's under aspirin, we must stop the aspirin before doing ESD or even mucosal resection? You?
For my individual opinion, aspirin can continue, but currently the society recommend stopping aspirin. I think aspirin is not that risky, and that's because during the procedure we control the bleeding by coagulating the blood vessels. So that kind of hemostatic procedure doesn't require the platelet to stop the bleeding. So I think just giving aspirin, I don't feel uncomfortable doing the ESD.
And aspirin.
Right.
You?
Yes, so same answer, but so regarding aspirin, of course, that is an antiplatelet. So even patient take aspirin, so we can perform procedure. But in a social reason, so I ask the cardiologist something to comment. We can stop it or not. So once we stop the aspirin, so patient potential risk to become some thrombosis or like that, heart attack. So anyway, important thing is ask the specialist and then get a comment. Yes, I think.
Okay. According to this, when you schedule a patient for ESD, you have a special informed consent?
Yes,
or it's
of
a
course.
regular informed consent for therapeutic endoscopy?
Oh, specific to
ESD procedure?
ESD procedure.
What you mentioned in this informed consent?
Oh, we mentioned, we explained how to treat the lesion, and the most important thing is the risk of complications. And when the complications happen, then they might require surgery. And in addition to that, the ESD procedure is not only the therapeutic procedure, that is a diagnostic procedure as well. So after successful resection of the lesion, we examine the specimen very precisely with pathological examination. And if the lesion is determined to have a high risk of lymph node metastasis, then they have to undergo additional surgery. That is very important to explain before the procedure.
So you mentioned in your informed consent.
Yes, yes, that is very important. Because if the patient thinks that this is the final treatment for them, and we tell them that you need surgery, then they think that's a failure. It's not a failure. That's a diagnostic procedure.
Okay. What about informed consent in your hospital?
Yeah, same too, Dr. Yamamoto. We have this set of the informed consent for each procedure.
What about POEM?
A POEM is also same. So we have of course, we got the informed consent from the patient, and we have the set of IC documents. Yeah.
Okay. So you do most of ESD in the stomach and into the esophagus.
Yeah.
There is debate for the esophageal lesion, both squamous and adenocarcinoma. I know that you see much more squamous than adenocarcinoma. Do you perform EUS for staging the lesions or not? Say the truth.
So epithelial. So far we use the ultrasonography, but now sometimes we skip the ultrasonography.
So you mean 90% of cases?
Yeah.
Sometimes.
Yes. because so if we it's a very delicate case, that is a mucosa or some mucosal invasion, delicate case. So finally, so we resect this. Anyway, we perform the ESD and then get the specimen, and then final diagnosis, accurate diagnosis on the specimen by his pathologist.
So you mostly rely on morphology or pattern and vascular pattern. What is the most important finding that we must evaluate to decide this is resectable or not?
So we combine the several information. So of course, when we see the lesion, so first we check the general figure, so elevated, depressed, and the color change, and then after that, so we perform the magnifying endoscopy and then check the vascular pattern.
Do you use Lugol from endoscopy?
Lugol is very nice to delineate, so we can identify the superficial spread.
Okay.
Make clear the margin of the lesion, Lugol.
Lateral margin.
In order to evaluate infiltration depth, so vascular pattern or so macroscopic change. Of course, some mucosal cancer has some elevation or some depression, so like that.
Okay. So just about rectal lesions that can be the target of the Western countries endoscopists, okay? Do you perform EUS for rectal lesions?
No, we perform, but selected cases. If the lesion has a possibility of curative resection with endoscopic ESD, then we perform ESD.
So most of the time you do not perform?
No. In the colorectal lesions, just endoscopic diagnosis using morphology and pit pattern diagnosis, those diagnoses are very reliable, and in most of the cases that's enough.
Can you shortly summarize how you decide ESD versus piecemeal EMR? I know that you like to do ESD to all patients because you like it, but overall?
Yes. Yeah. In general, if the lesion is homogeneous type LST granular lesion and the pit pattern diagnosis shows the regular 3L pit patterns and no large nodules, just a flat elevated lesion. Those kind of lesions don't have any
mostly benign,
so just piecemeal is enough. But myself, I perform ESD because I'm used to doing ESD, so for me it's more comfortable doing ESD rather than piecemeal resection.
Like us.
Yeah.
So, what about you?
So, in a gastric, I generally recommend unblock resection
Always.
always.
So even if the lesion is small, smaller than 2 centimeters, that you could potentially resect with your cap, you still see indication for cap mucosal resection into the stomach, into the esophagus?
So in the stomach, so depend on the location of the tumor, but the generally less than 1 centimeter region can be resected by cap EMR. And the esophagus, we can get a more mucosa in a one cap EMR. We can get a larger specimen. So in the esophagus, we can apply the cap procedure less than 2 centimeter region.
Okay. So for stomach lesion, for gastric lesion until 1 centimeter.
1 centimeter.
For esophageal lesion until 2 centimeters.
Yes.
That can be done by cap.
Yes.
Do you use the largest one, the soft cap, or you use the regular cap?
I prefer use hard and large. Soft and large.
The oblique one or the
oblique
straight one?
Oblique one.
The oblique one.
Hard but large one.
Okay. I would like to ask you a list of the most easiest part where to start for the beginners with ESD. Is the distal stomach for you? Which
Yes.
side? The posterior wall, the anterior wall, the angle?
Anterior wall of the antrum is the most, the easiest part. And anterior wall or greater curvature of the antrum, that's the easiest part.
And the second easiest part?
Second easiest part is the posterior wall of the antrum, and the lower body of the lesser curvature is also easy.
What about you?
Totally same to Dr. Yamamoto.
Yeah. And what about rectum?
Rectum is usually.
We believe it's easy, but isn't. We believe that rectum can be very easy, but sometimes it's not easy.
Right. Rectum could be
Quite tough.
Yeah, quite tough because most of the colorectal lesions they don't have big blood vessels, but in the rectum it's different. In the rectum you could have large blood vessels and it could make bleeding, and sometimes the injection doesn't work very well, and sometimes the approaching angle is very tough even in the rectum.
I think that most of the people here, they can remember at least one case. They saw a nice rectal lesion. They tried to infiltrate the lesion. They started cutting. They saw a lot of blood coming out, no? So the suggestion is how to avoid, at least in the beginning of the procedure, that big bleeding when you are starting the cut.
Okay, in the rectum, and you should avoid deep cutting when you perform the mucosal incision. And the mucosal incision is a kind of blind cutting. When
You are very close to the mucosa, no?
No. I mean, after you go into the submucosal layer, then you can see the blood vessel, and you can
Okay, I understand. Okay.
selectively coagulate the blood vessels to prevent the bleeding. But when you cut the mucosa, you don't know where the blood vessels are. So for the very easy bleeding person and rectal lesion, and when you start cutting and it starts to bleed, then what I do is on purpose I cut just very shallow mucosal incision to avoid the cutting of the blood vessels.
So from the beginning, your suggestion, keep a little bit superficial?
Yeah, superficial cutting, and after cutting the mucosa, you can see the blood vessels. Then you can coagulate the blood vessels and start the dissection. And once you go deep layer to the muscle layer, then you don't see many blood vessels. The most of the blood vessels are just
Close to the mucosa.
close to the mucosa.
Where we put the knife and we get the bleeding.
Right, right.
So, what about you for gastric lesions to avoid the bleeding in the beginning, in the first part of the procedure? You make a superficial cut too, or you have special tricks?
Same mechanism. So we put the superficial cut first, and then we get into the lamina muscularis propria, lamina propria mucosa. So we can see some vessels. And then, so sometimes we coagulate. Sometimes we use coagulating forceps, and sometimes we cut directly. But anyway, so identify the vessel, and then approach. And then after getting into submucosal layer, so vessel structure is like a tree.
There is the root.
Root, and then a branch.
Yeah.
So that is a style. So generally, it's better to approach a deep layer and then cut the root of the.
Okay, I understand that the hemostasis is a very crucial part of the procedure.
Yes.
To keep the endoscopic field very clear, okay, and clean. So how you do hemostasis of the vessel into the submucosa? You use your knife or you always use the coagrasper?
It depends on the size of the vessel.
So what is the line, the guideline?
So needle part of the device, any device. So usually that is a 0.4 or a 0.5 millimeter outer diameter.
The tip.
Not a tip. So it's an axis.
The axis. Okay.
Needle
okay.
part. Needle
Okay.
part is a 0.4 millimeter or like that.
Okay.
So if the vessel is larger than the needle, so it's better to coagulate. So it's very simply speaking.
Okay.
So
This is a good suggestion. Excellent suggestion.
Yes.
What about you?
Yeah, the same. But I want to explain how to coagulate using the knife itself. Most of the doctors who start performing ESD, when they find the blood vessel, they want to attack immediately. But that's
Do not attack the blood vessel.
No,
They are dangerous.
That's dangerous. And attacking the blood vessel with the tip of the knife, that will make a hole in the blood vessel and make bleeding. That's not a good idea. What I will suggest is leave the blood vessel and dissect around the blood vessel, then coagulate with not the tip, with the side of the knife. Then you can coagulate, hold the blood vessel and stop the bleeding. Then you can coagulate, and then you can see the blood vessel is whitish and no blood flow anymore. Then that's the time you can cut without bleeding.
So very important recommendation. Which setting for coagulating the vessels? Go with the setting.
I prefer using spray coagulation.
What is spray coagulation? Because we don't have a spray coagulation on our herbe machines.
Mm-hmm. Yeah, but you can use forced coagulation as well. But you have to understand how the electric generator works, and the cutting current and the coagulation current. The difference is the voltage. the coagulation current has a higher voltage but lower wattage. And higher voltage with lower wattage, that causes coagulation without cutting. And if the voltage is low and wattage is high, then you can cut. So for the coagulation, you just want to coagulate the blood vessel without cutting. So the spray coagulation has the highest voltage. If you choose spray coagulation with bio and effect 2, 4,000 volts you can generate. But by decreasing if you use just a tiny needle device and duration of the application of the electricity is short enough, then the coagulation effect is not that deep. So you have to control the time. You shouldn't press the foot pedal for a long time when you use spray coagulation. That's too powerful and coagulate to the deep muscle layer. That's risky. So just for a short time, but with a high voltage, you can have a best coagulation.
I don't think these are excellent suggestions. So what about you?
Yes, so for example, when we perform the POM procedure, so most of the vessel can be controlled by the spray coagulation. At the time I use a spray coagulation 50 watt and effect 2. So
50 spray coagulation, 50 watt effect 2.
So that is a very nice mode to control the bleeding. So most favorite. But sometimes it's too strong when we perform the ESD. So then achalasia patient is okay. So because they have a very thick muscle layer, so no risk of perforation. But when we use the spray coagulation like that in a normal, what I mean in a ESD case, they have the normal muscle layer, so very thin. So at the time, so we may have a potential risk of muscle injury. So we reduce the power a little bit. But generally, spray coagulation works very well to control the bleeding. So in order to cut the connective tissue, so we can use a cutting current. Also, we can use it. So if there is no vessel, we can use a cutting current. And then when we approach the large vessel, when we approach small vessel, we can use a forced coagulation or swift coagulation mode. Coagulation
so
and the
you
cut.
You change the setting if you use the coagrasper?
When we use a coagrasper, that is a special mode.
What is your mode?
Soft coagulation, 80 watt effect, 80 watt effect 5.
So,
yes.
80 watt effect 5. Forced coagulation.
Yes.
Soft coagulation.
Soft coagulation for coagrasper. Okay.
Right.
A little bit higher voltage.
No, the soft coagulation has a low voltage, but automatically the electricity goes down before it cuts. So just coagulate. So that is a totally different concept. So soft coagulation has only 200 voltage or something like that, not very high, but it automatically decreases the wattage, and so it doesn't cut. So that's a different concept. And I want to talk about the spray coagulation a little bit more. Dr. Inoue told that 50 watts, but 50 watts is too strong for ESD. And if you want to use spray coagulation for just coagulation, not like the Dr. Inoue perform poem, then I recommend you to use a much lower voltage. I usually use between 5 watts to 30 watts. And when you apply the current and you think the power is too strong, then you can adjust. And I sometimes decrease to the minimum, that is 5 watts. So using the flash knife, just 5 watts and effect 2, that's enough for the coagulation.
Why you didn't start poem yet?
Oh, I will.
Will?
Yeah, yesterday I saw his procedure, and that's a very good procedure.
So did you pay for training your colleague, your Japanese colleague yesterday? Okay.
Yes.
So you are ready to go?
Yeah, I think
You want
so.
to start?
Yes.
Okay. Pay attention, you have a big competitor now. Eh? So one of the issues is sedation of the patient. So which sedation for upper GI ESD? You intubate all the patients, you do under mild sedation. I was impressed when I came in Japan because most of the patients have been done just under mild sedation.
Yeah, so most,
Japanese are different than Italian, eh? You must understand. Eh?
so generally, we perform the conscious sedation ESD procedure. But in a tough case, it's better to do the procedure.
So when you
in
expect a long procedure?
Yes, more than expected, more than 2 hours. So or fibrotic, complicated, a pluralist patient, and then particularly the patient of the esophagus. It's better to do under general anesthesia.
So what do you mean contrasedation? Can you give us the protocol of sedation?
We can use just use midazolam or propofol or any
Petidine
kind
or
of
fentanyl?
petidine. Yes, petidine and the diazepam. No.
And you do
We
by
can-
yourself or with an anesthesiologist?
We do it by ourselves for conscious sedation, but of course for general anesthesia. Right.
So what about sedation of colorectal ESD?
Oh, colorectal ESD usually require less sedation. So we perform colorectal ESD with conscious sedation. As long as you avoid over-insufflation, patients don't feel any pain, and just with conscious sedation, they can tolerate very well. And keeping the patient conscious, then you can use the
For rotating?
rotating the patient. They can
Using the
rotate
gravity,
themselves.
no?
Yeah, so-
To adjust
right.
the lesion.
Yeah, that's right. So we use conscious sedation for lower ESD.
This is the same for lesion very close to the anal verge that can be very painful.
Yes, but in that case, I mix a little bit of lidocaine to the submucosal injection for the very low rectal lesion, and you have to cut the anal canal first. Then for that injection, I use lidocaine.
Okay.
Local
Okay.
anesthesia.
So we just arrived to the solution to be injected. So you are aware that we cannot use hyaluronate because it's very expensive in Italy as well as in Japan. What is the solution that you use? You have potential alternatives to hyaluronic acid?
So when we use, for example, flash knife, maybe Dr. Yamamoto will comment it, but when we use a flash knife, so we can get the anytime elevation of the mucosa. So it's not necessary to use hyaluronic acid, but it depends on the case. So without hyaluronic acid, so using a saline injection, we can get, or glycerol injection, we can get a nice lifting, so it's not necessary to use a hyaluronic, just cut it.
What about epinephrine?
Epinephrine, so generally we use epinephrine. So of
Which
course,
dilution?
Couple
of
I
vials.
forgot that a few drops of epinephrine.
Couple of vials. More Italian than Japanese way, you know.
Yeah, we use
Italian recipe.
we use more diluted epinephrine.
You don't use epinephrine?
Yeah, we use the epinephrine, but only 0.1 milliliter to 10 milliliters. So that is
Very diluted.
yeah, very diluted. I think 10 times
like
more
nothing, eh?
diluted than the European.
You put some drops of staining substances?
Yes, indiocarmine, yes.
So
I
the color of the liquid to be injected should be light blue or true blue?
Light blue.
Very light blue?
Yes, yes. Very dark blue, then you cannot see the blood vessels very well.
That's
so
his suggestion.
The light blue.
So pay
is the
attention
best.
to make.
Yes.
Do you believe the same?
A little bit thick. So I mean a little bit dark blue. So feel more cool.
So more dark, less dark. Okay?
Less dark.
Okay. There are different way of approaching the lesion. So when you see a lesion, you have the lesion in front of you.
Yes.
You start cutting the mucosa from the endoscopy side or from the opposite side?
Oh, usually from endoscopy side. I started.
Your first mucosal cut is on that side.
Yes, yes. When I started the ESD, I was cutting the distal side first. But recently I changed.
Why?
Because that side can be cut any time before you finish the procedure. If you make a cutting that side, then the injected fluid flows out from the incision.
That's a good
So
suggestion.
before the
Use like a barrier to contain.
right, that's right. So usually the approaching direction, the easier approaching direction is just going straight. So the easiest approach I use for the most of the dissection, but you have to make the final the incision of the distal side. Distal means the far side.
Most distant from you.
Yeah, that's right. Before you dissect too much, once the dissected specimens flip back, then it becomes really difficult. So before such kind of situation happens, you must cut it. Yes.
Okay. How you do?
So generally, we cut first the distal end.
So on the
Distal
other
end
side.
first. Yes, so other side. So that means we decide the exit of the tunnel.
So most
first.
of the time you start in a J position into the stomach on the other side, or you in the frontal way?
So it's depend on the location of the lesion. So we check, of course, we do not decide before starting the procedure. So watch the region and then simulate. So approach from the forward view or a lateral flex view, and then which is more so simulate, and then easier to control the endoscope. And then after that, so we decide the approach from proximal or distal. Anyway, so in an endoscopic view, after deciding, for example, if we decide in a retroflex view, so in the view, so we first cut the distal first, and then decide the exit of the tunnel, and then actually approach from the proximal to distal.
Yes, I think you have to change your mentality when you perform ESD. ESD is not just an endoscopic procedure. That should be considered as endoscopic surgery. So it's totally different from the just regular pulpectomy and diagnostic endoscopy. So you have to make a strategy first. And so recently we have a conference just before the ESD procedure and discuss what kind of approach is the best and what kind of strategy we use and what kind of device we use. And with that discussion, we make the best strategy. And then you can estimate the time you need. So you have to allocate the time. Otherwise, the endoscopy unit will become crazy. So you have to change your mind.
You know, you travel a lot, visiting many Western countries. I understand that many times you have dealt with this kind of problem. The issue is that everybody would like to start with the ESD procedure, but it's very tough to get trained in Western countries. And not all the Western people can come to Japan to do the training. So how we can set the training in Europe? So very practical suggestion how we should start.
Yeah. So first step is the watching the procedure of the expert. So any expert, it's okay. So anyway, so watching the procedure. So during 2 hours procedure, you can see some bleeding situation or sometimes perforation. So watching is first, and the second is using a model you try to do. So of course the animal model.
Pig model
is good, I think, to do the procedure, and but the pig model is also very expensive. So you can use some resected specimens of the animal. So that is a specimen from the pig, just the
Stomach.
Yes, stomach or like that. So it's a very nice experience. So after that, so approach to the human.
I think a very dedicated endoscopist who really wants to become ESD specialist is needed. Once very specialized, good endoscopist exists, then that person can teach.
So first must be a good therapeutic endoscopist.
Yes, and the establishment of the trainer is the beginning. You have to have a good trainer, otherwise you cannot get the good training. So establishment of the trainer.
How many procedures are done under your tutorial with your fellows because they are considered fit for starting?
By themselves. 50 procedures.
50 procedures.
Yes.
So this will be probably impossible for the Western setting.
But you have many colorectal lesions, I think. The rectum and are not that big.
So start with small lesion.
Yes.
2 to 3 centimeter lesion.
2 to 3 centimeters, yes.
Okay, and always with the distal attachment on the tip of the scope.
Right. Yeah, distal attachment is very, very important.
Stretch the mucosa.
Yes.
So how many procedures before being able to do?
Yes. So when we start the ESD procedure, we have a lot of complication. So 30 cases.
We too. Don't worry. Same, even higher.
So first 30 cases, we experience many things. So bleeding, late onset bleeding, or perforation, everything we experience. So please, very careful to the
But
first.
my opinion, the most important part is scope manipulation during the procedure, because scope manipulation is completely different than standard endoscopy, as Dr. Yamamoto mentioned it before, no?
Yeah.
So do you have a special position for scope manipulation? You manipulate the scope by yourself? You have an assistant pushing and pulling back?
No.
So you manipulate the scope completely by yourself. You manipulate the handle and the device.
Yes, and the if I need a third handle, we use
They use the stomach.
our belly, abdomen. We use.
This they hit a lot. No?
So, but the important thing is so very precise movement and a very precise. So, in my mind, so when we perform the ESD or POM, I think always dissection 1 millimeter. Anytime 1 millimeter, or sometimes a 0.5 millimeter dissection. And then a combination of them, we can complete the procedure. So
Just a shortcut.
So yes, very shortcut. Accumulation of shortcut. So what I want to say is that the control everything, control scope, and control the tip of the needle. In order to control the tip of the needle, we have to control everything. So
but most of the time, you move the scope, you don't move the device. So the device is stationary into the working channel, and you advance the tip of the scope for cutting. Is this true?
Yeah, most of the time that's true, but it's not the case all the time. Sometimes the insertion of the endoscope makes the paradoxical movement, and in the colon sometimes happens, and even in the stomach and near the angle of the stomach. And if you try to push, then they just move like this. So in that case, the insertion and withdrawal of the endoscopic shaft doesn't work. So in that case, I just stabilize the endoscope shaft and use the control of the knife to dissect. And I want to emphasize that most of the endoscopists, they move endoscope too much. Just a little bit of movement, and the tip of the endoscope moves a lot. So you don't need to move a lot. So what I'm trying to do is try to avoid unnecessary movement, and just a little bit of movement, and that's enough. So that is very important.
Okay, we touched a lot of different aspects of this procedure that remains for us a sort of a dream. So now I would like to open the discussion to all the questions that you have. So,
two short questions. First of all, there's a tendency in the stomach lesions to make a cut circumferential around the lesion, and that we're leading for more bleeding on the other side of the lesion. Why not always just start the one end and keep cutting once you're under the mucosa, and then you can see it. And we all still see that making a round cut. That's the first question. Two is in the colonic lesion for Dr. Yamamoto. And occasionally you have a non-lifting sign, but the lesion you did it, you thought it may be a fibrosis, rather than a deeper sort of how do you differentiate? Is it a fibrosis?
That's a good point.
A deeper invasion.
So, non-lifting sign, fibrosis versus deep neoplastic infiltration. Okay, that's the question.
Okay, the depth of invasion is diagnosed by the endoscopic findings using the magnification and the pit pattern diagnosis. And as long as there is a high possibility of the mucosal lesion or just the tiny, a little bit of submucosal invasion, and then I perform ESD. And even with the non-lifting sign exists, and I complete the ESD, and the pathological diagnosis will tell you the truth. But it's almost impossible during the procedure whether that is a fibrosis or invasion.
Okay.
So, yeah, it's almost
So
impossible.
macroscopically, you cannot recognize.
Right. So you
cannot
have to make
distinguish.
a diagnosis beforehand.
If there is a non-lifting sign, is it safe to continue, or the risks are higher to perforate?
Yeah.
Say, for the non-expert,
no
not for you.
expert.
For the
no
non-expert.
expert. It's risky. It's
Very
risky.
risky. That's the message. Very risky.
Very
so pay
risky.
attention.
You have to have a good ability to control the knife. Just you are aiming at only very 0.3 millimeter or so. So the 1 millimeter is too big. If you cannot control 1 millimeter, then it's not recommended.
Okay, more questions? No more questions. We are at the end of this session. You did a fantastic job. Many thanks indeed. You have deserved a big pizza, Italian pizza tonight, so you are invited to have a nice pizza. I want to say that was extremely useful for everybody in the room because we got several nice tricks that we can use for starting our procedure. If I can summarize, you said that there are specific indications for performing this kind of procedure, and you have a dedicated approach. We should change our mind, becoming a specialist in ESD after being specialist in therapeutic endoscopy. And we must plan very well what we do, okay?
Right.
Doing a lot of simulation, even endoscopically. And there are different technical aspects that you can do in a different manner, but overall, superficial cut of the mucosa in the beginning to avoid bleeding, and afterwards, very careful hemostasis, okay? The liquid of injection doesn't matter too much, I understand, even without hyaluronic acid, we can do, okay?
Yes, but
It will be better.
acid is better.
You
can dilute.
Now we use a diluted hyaluronic
The
acid.
distal attachment, the distal hood, it's very important. So please don't start doing ESD without the distal attachment on the tip of scope. You can select the knife that you prefer according to your training program, to your special preference, but always very short tip into the colon to avoid deep cut, okay? And last point that you mentioned is ESD can be performed at least into the colon with contrasedation. We don't need deep sedation.
Right.
But probably what we missed is the importance of CO2 insufflators.
is very important,
So
yes.
don't start doing ESD resection without CO2 insufflator. Can you say a few words on this before closing?
Yeah, using CO2, that makes the procedure much easier and comfortable for patients. And even if you over-insufflate a little bit, but that will be absorbed. And but the most important thing about CO2 is when you make a complication like perforation. Perforation happens, then if you use air, the air goes into the abdominal cavity or retroperitoneal space, and that could go to the lung and make pneumothorax, and cardiac arrest will happen. So that's very risky. In order to keep the endoscopic view, you want to insufflate, but because of the perforation, the air leaks. So continuing air insufflation, then the respiratory arrest and cardiac arrest ensues. But using CO2, the leaked CO2 is quickly absorbed. So you have enough time to close the perforation with clip. So CO2 is very, very important.
Many thanks indeed to both of you.
Thank you.